Okay, good morning everyone. Today we are going to continue with our book club activity on the chapter of diffuse lung diseases from the fundamentals of diagnostic radiology. Our colleague Dr. Sarbest will present this presentation.
Good morning. Thank you, Dr. Ahmed, and good morning, everyone. Let us start with our subject, part of the diffuse lung disease. We know that diffuse lung disease are broad spectrum of disorder. They affect the pulmonary interstitium, and we should know that their presentation is not acute. Usually, they are either present with progressive dyspnea, and even sometimes they are asymptomatic, and they are diagnosed incidentally or during screening for other diseases, like in evaluation of collagen vascular disease like SLE, rheumatoid, arthritis, and other diseases. Their diagnosis by chest X-ray is difficult in their early stage especially, but with the advent of thin section CT, now they are diagnosed in their early stage, and CT has revolutionized the diagnosis of the interstitial lung diseases. Thin section CT demonstrates the normal anatomy very well. In the case of lung disease, we have three types of interstitium: central, centrilobular, subpleural or peripheral interstitium, and finally intralobular interstitium. Central interstitium surrounds and begins at the hilum and extends peripherally. It surrounds the peribronchovascular structure, and when it extends peripherally, the central interstitium surrounds the centrilobular structures. They are located in the center of the lobulus. At the same time, you have peripherally, you have subpleural interstitium, which are located between the visceral pleura and the lung surface. Interstitium extends as septa, separating the lobulus from each other. It is termed subpleural or peripheral interstitium. Normally, on thin section CT, we can see just the subpleural or peripheral interstitium, while central, centrilobular, and intralobular interstitium, they are not seen. Each secondary pulmonary lobule, they are polygonal or polyhedral in shape, supplied by 3 to 5 terminal bronchioles, and they are separated from each other completely by interlobular septum, or it is called subpleural or peripheral interstitium. We can benefit from thin section CT in the assessment of diffuse lung disease when the chest X-ray they are normal or questionable, and we suspect the interstitial lung disease. Even at that time, thin section CT can be used for their characterization of the parenchymal abnormality and help in the biopsy planning. For example, their route, whether transbronchial, open, or bronchoalveolar lavage. And when showing the biopsy route, it can help us to take biopsy from areas of active disease and not from area of end-stage fibrosis. Finally, thin section CT can be used for monitoring to response to treatment or in reverse for the progression of the diseases. This slide is from the thin section CT scan of the upper lung, showing the interlobular septum. They are thin, about 0.1 mm thick, and between them in a secondary pulmonary lobule, we show these wide dots from centrilobular arteries. Each lobule contains centrilobular artery. This is the pulmonary artery denoted in blue, and the pulmonary veins, they are located in the interstitium between the lobulus. There are some thin section CT signs of diffuse interstitial disease or diffuse lung disease. Most important is the interlobular septal line or septal thickening. They are either peripheral in the lung. Where it is located peripherally, they are thin and short, about 1 to 2 cm. They are perpendicular to the lung surface and intersecting them. They are normally seen, but in disease state they are thicker than 1 mm and they are more numerous. They are most common in the interstitial pulmonary edema, idiopathic pulmonary fibrosis, and lymphangitis carcinomatosa. The peripheral septal lines are equivalent to the curly B line in chest X-ray, while central septal thickening, they are longer. They are located near the hilum, about 2 to 6 cm diameter, and they are equivalent to the curly A lines in the chest X-ray. This slide shows the thickened interlobular septum, and at the same time it shows the fissural thickening. This is a case of Langerhans cell, a case of lymphangitis carcinomatosa. Intralobular lines, they are located within the lobulus and radiating out toward the thickened lobular border. You have thickened septum and also intralobular lines in a spoke and wheel or spider web appearance. They are normally not visible, and they are due to thickening of the intralobular interstitium, which normally cannot be seen. They are usually seen in the case of fibrosis and end-stage diseases like idiopathic fibrosis and other causes of usual interstitial pneumonitis. This is magnified view of secondary pulmonary lobule. This is secondary pulmonary lobule. This is the thickened interlobular septum. This is irregular, and these are inside the lobulus, and these are the intralobular lines. This is a case of interstitial pulmonary fibrosis. Other sign is thickened fissure. Thickening, it is due to thickening of the subpleural interstitium, and because fissures are 2 layers of visceral pleura, so it contains 2 subpleural interstitium outlined on either side by air. They are either smooth in the case of pulmonary edema, or nodular in the case of sarcoidosis and lymphangitis carcinomatosa. This is a case of thickened interlobular fissure. Thickened bronchovascular structure, we said we have axial or axial interstitium, which is located near the hilum and extending peripherally. Thickening of peribronchovascular interstitium on the thin section CT appear as enlargement of the perihilar vascular structure and bronchial wallus, as in this picture, thickened peribronchovascular structure. On chest X-ray, they appear as peribronchial cuffing and tracking. They are either smooth.
The walls of the bronchi parallel to each other, like
Or peribronchial cuffing.
the wall of the bronchus.
Cuffing. They are either smooth in the case of pulmonary edema, or nodular in the case of sarcoidosis. But Langerhans, but lymphangitis carcinomatosa can cause either smooth or nodular thickening. We see this is a case of lymphangitis carcinomatosa, thickened peribronchial interstitium and bronchial wallus. This is centrilobular or lobular core abnormality. Inside the lobulus, thickening of the axial interstitium, meaning abnormal prominence of the dot-like or branching centilobular arteriole, seen in pulmonary edema, lymphangitis carcinomatosa, and usual interstitial pneumonitis. Normally, artery is seen, but in the case of disease, it is thickened. While centilobular bronchulus normally not seen, but visible as a result of either luminal dilatation or thickened centrilobular arteries. As in this case, these are ill-defined nodules. These are dilated and thickened bronchulus, normally not seen. This is a case of hypersensitivity pneumonitis. Another sign in thin section CT in diffuse lung disease is parenchymal bands. The parenchymal bands are non-tapering linear opacity. They are long, about 2 to 5 cm, extend from the lung to contact the pleural surface. And they are distinguished from vessel or thickened septa by their length, because they are long, and their thickness coarse. They are extending to the pleural surface. They are not branching and associated with regional parenchymal distortion. They are frequently seen in asbestosis, pulmonary fibrosis, and sarcoidosis. One important sign of diffuse lung disease in thin section CT is honeycomb cystis. Honeycomb cysts usually indicate an end-stage disease with the development of fibrosis. They are small cysts, 6 to 10 mm thick. The thickness of the wall is 1 to 3 mm. It is regarded as thick wall. Mostly in the subpleural region of the lower lobe peripherally. They result from, as we said, end-stage pulmonary fibrosis, and at the same time, sure, there are additional signs of interstitial disease. They are frequently seen in usual interstitial pneumonitis and chronic hypersensitivity pneumonitis. This is a case of intrinsic idiopathic pulmonary fibrosis. We see in the lower lobe peripherally. These are the cystis, honeycomb cystis. How we differentiate thin honeycomb from other cystis? Thin walled, we have also thin walled cystis, common in the late stage of some diseases like Langerhans histiocytosis and lymphangioliomyomatosis. Usually cystis in this condition, LAM and LCH, they are larger. At least 10 mm, while honeycomb maybe 5, 6 to 10 mm. They have thinner wall, while honeycomb they are thick. Thin wall cystis have shaded walls. There is thin wall cystis, there is no shaded wall. In the case of honeycomb, they are closer to each other. One wall may be shaded.
The cysts are just direct to bronchioles. So bronchioles speak with each other. So they share the wall.
Yes.
While the thin wall cysts, they are just separate, scattered cysts.
This is the reverse. Thin wall cysts are evenly distributed from central to peripheral, upper lobe, plus minus lower lobe, while honeycomb cysts tend to occur in the subpleural lower lobe. In the case of thin wall cysts, normal lung may be found between the cystis, while in the honeycomb, uniformly destroyed the lung. It is difficult to see normal lung between the cystis. This is a case of lymphangioliomyomatosis with thin walls. We can see normal lung tissue between the cystis. They are thin walled. In the case of lymphangioliomyomatosis, the cystis are of different size, but they are of different size. Another case of lymphangioliomyomatosis, thin wall cystis. They are evenly distributed from center to the periphery. Although in the case of lymphangioliomyomatosis, the cystis are of different size, but they are of uniform in shape. They are round, but different size. Another sign is irregularity of the lung surfaces. It's a common sign of interstitial disease. It is either between the bronchovascular bundle and the surrounding lung, or between the fissure or pleural surface and the surrounding lung. It is commonly seen in the usual interstitial pneumonitis and sarcoidosis. They are most common cause. We see this is an interlobular septal line, thickened, and it is irregular. So it is between the bronchovascular bundle and the surrounding lung. And we say these are the intralobular lines, thickened. Another sign is micronodules. They are small, 1 to 3 million. They are sharply marginated, round opacity, located within the interstitium. They are either central, near the hilum, in the case of sarcoidosis and Langerhans cell histiocytosis, or they are interlobular in the interlobular septa or subpleural, again in sarcoidosis, lymphangitis and silicosis, or they are within the substance of the pulmonary nodule, like in metastatic adenocarcinoma and miliary granulomatous infection. The central and interlobular septal interstitium, they are regarded as perilymphatic distribution. As in this case, this is a case I think of silicosis, show on the chest X-ray scattered nodules and conglomerate mass, and also in the case of CT, these are the nodules, subpleural nodules and conglomerate masses. An important sign is ground glass opacity. Ground glass opacity is increase in the attenuation of the lung, but within which we can see the normal parenchyma, we can see the blood vessel inside it. They are due to thickening of the alveolar septa, which is normally not seen. And even after pathology, we cannot see the alveolar septa. This is a pathological term. They are common in diffuse interstitial, disquamative interstitial pneumonitis, PCP, pneumocystis pneumonia infection, acute hypersensitivity pneumonitis, and other conditions. Ground glass opacity occasionally confined to the immediate centrilobular region of the lobule. They are just affecting the area in the lobule surrounding the bronchioles. At that time, they appear as ill-defined centrilobular nodules. Again, this is seen in hypersensitivity pneumonitis and cryptogenic organizing pneumonia. The importance of ground glass opacity is that ground glass opacity indicate that the process is active and there is active inflammation or edema, and it is reversible and needs aggressive treatment. In the late stage of interstitial lung disease with fibrosis, there will be architectural distortion and traction bronchiectasis due to extensive parenchymal fibrosis, creating irregularities of the lung with the mediastinum interface, or lung with the pleura, or lung with the vascular interface. Most common condition that reaching these stages are sarcoidosis and usual interstitial pneumonitis. We see in this, these are honeycombing, subpleurally located, and these are traction bronchiectasis. Traction bronchiectasis are due to fibrosis which cause traction on the walls of bronchi and resulting in irregular dilatation. They are usually segmental and involving segmental and subsegmental bronchi, but at the level of the intralobular level, maybe intralobular level, it causes honeycombing. Traction bronchiectasis by itself causes honeycombing, and most commonly seen in the usual interstitial pneumonitis, but can also be seen in fibrotic sarcoidosis and radiation fibrosis. Conglomerate mass, as we said, in extensive fibrosis, fibrotic tissue will conglomerate and form parahilar masses in the upper lobe region, and it is often associated with peripheral bulla, seen in end-stage sarcoidosis with complicated silicosis with progressive massive fibrosis. And we see in this case there are nodules with the conglomerate masses in the upper lobes in the case of silicosis. Consolidation is increase in the density, but it differs from the ground glass opacity that the underlying normal structure can not be seen. In ground glass opacity there was no bronchogram, but in the case of consolidation, bronchogram are common. Consolidation can be seen as in any airspace filling process, pneumonia and any other disease, but sometimes diffuse lung disease can present with consolidation, like in usual interstitial pneumonitis, sarcoidosis, and cryptogenic organizing pneumonia. This is a case of cryptogenic organizing pneumonia. In the chest X-ray, you see patchy area of consolidation and airspace of ossification, and in the thin section CT, we see peribronchial opacification and areas. There are areas of airspace of ossification. We discussed the signs of interstitial lung disease on the thin section CT. Let us go to the chronic interstitial lung disease. Chronic interstitial lung disease denotes diffuse inflammatory process, any diffuse inflammatory process that affect the axial and parenchymal interstitium of the lung. They are caused by a variety of disease, a broad spectrum of diagnosis. We cannot diagnose chronic interstitial lung disease on the basis of CT alone. We should share the evaluation of radiological study, clinical correlation, and also with the lab data. Even at that time, majority will require a histological examination for definitive diagnosis. You have chronic interstitial pulmonary idiopathic IPE, chronic interstitial pulmonary edema. Chronic interstitial pulmonary edema, it is due to chronic elevation of the pulmonary venous pressure, which lead to increase in the interstitial marking on chest X-ray, and interstitial thickening is caused by either distension of the pulmonary lymphatic because of the increased pulmonary venous pressure, and chronic interstitial edema. They are mostly seen in long-standing mitral stenosis or left ventricular failure. In the chest X-ray, we see signs of increased pulmonary venous pressure or pulmonary venous hypertension. We see peribronchial coughing, tram tracking, poor definition of vascular marking, some reticulonodular opacity, upper lobe venous diversion, and prominence of the fissures. All these signs may be seen in chronic interstitial pulmonary edema on chest X-ray. But honeycombing is not a feature of chronic pulmonary venous hypertension. And when it is present, we should suggest other sign of pulmonary fibrosis in patients with these diseases like mitral stenosis and left ventricular failure, maybe due to amiodarone lung toxicity. Other topic is connective tissue disease. The most common thoracic manifestation are due to vasculitis and interstitial fibrosis, but pleura, chest wall, diaphragm, and heart may also be affected. Rheumatoid lung disease, extra-articular manifestation of rheumatoid is seen in about 75% of patients. Pulmonary involvement is more common in men, and the pleuropulmonary manifestation either follow the onset of joint disease, which is in the majority of cases, and or the pulmonary manifestation precedes the joint disease in about 15% of cases. Let's start with parenchymal involvement. Parenchymal involvement in the rheumatoid arthritis usually appear as fine reticular or ground glass opacity with lower lobe predominance, as in this case, coarse reticular shadow we see in the lower lobe, and gradually it will progress to end-stage pulmonary fibrosis, as in this case. This is peribronchial reticulation. It's the early stage of rheumatoid arthritis. These are rheumatoid nodules with cavitation and some ground glass opacity. Less common parenchymal manifestation is lung nodules. The rheumatoid nodules, they are located peripherally. Cavitation is common, but when rheumatoid arthritis occurs in patients with coal miners, silicosis, and asbestos workers, it's called Kaplan syndrome. How we can differentiate in this condition? Because the nodules are the same as simple rheumatoid arthritis. In these cases, we see small nodular and parenchymal opacities of simple pneumoconiosis. And we see the rheumatoid nodules in a background of nodularity, which indicate Kaplan syndrome. We say the rheumatoid arthritis usually lower lobe peripheral, but rarely maybe predominantly upper lobe fibrosis, cavitation ampulla. At that time, it is important to differentiate them from ankylosing spondylitis and post-primary fibrocavitary TB. Other parenchymal manifestation is cryptogenic organizing pneumonia and bronchiolitis obliteranis. They are clinically, functionally, and radiographically similar to this condition, I mean COP and bronchiolitis obliteranis from other conditions like in SLE, drug, and viral infection. Cannot be differentiated. Pleuritis is the most common thoracic manifestation of rheumatoid arthritis, which occur in 20% of patients. Uncommon manifestation is pulmonary arterial hypertension due to with enlargement of the central pulmonary artery and right ventricular dilatation. They are mainly secondary to diffuse interstitial fibrosis, but rarely may be part of systemic vasculitis. At that time, when there is pulmonary arterial hypertension due to vasculitis, it is not provided to see associated parenchymal abnormality. We have chest wall manifestation on rheumatoid arthritis other than parenchyma. You may see erosion of the distal clavicle, rotator cuff atrophy cause high riding humeral head. We may see glenohumeral joint space narrowing with degenerative change, superior rib notching, and erosion is other feature. Another connective tissue disease is SLE. The thorax is commonly affected, maybe the initial site, as in the case of rheumatoid arthritis, maybe the initial site of manifestation. Usually the disease SLE is limited to the pleura and pericardium, which cause exudative pleuropericardial effusion. In the long-standing cases, there will be diffuse pleural fibrosis and thickening, as in this case we see bilateral pleural effusion and pericardial effusion. We see also there is a thickening of the pericardium and enhancement. Although the disease mainly affects the pleura and pericardium, but lung, heart, diaphragm, and intercostal muscle are involved in 1/3 of patients. Parenchymal manifestation of SLE include acute lupus pneumonitis and chronic interstitial disease. The acute lupus pneumonitis is a rapid onset with diffuse alveolar damage. Chest X-ray show rapidly coalescing bilateral airspace opacification, like patient with acute respiratory distress syndrome, and CT shows ground glass opacity. This is diffuse ground glass opacity. It is difficult to distinguish from other conditions, which also they are present in SLE, like hemorrhage from pulmonary vasculitis in SLE, or pneumonia from immunosuppressive therapy which patient taken, or edema due to renal failure. Yes. So to diagnose lupus pneumonitis from these, the hemorrhage, from edema, or from pneumonia, so we should exclude pneumonia and pulmonary edema. And we see improvement with immunosuppressive therapy, rapid improvement in acute lupus pneumonitis. Does SLE cause fibrosis? It's uncommon radiographically. When fibrosis is present, it is present in 1/3. It is basilar reticular opacity. But if severe fibrosis occur in SLE, this may be due to overlap syndrome, meaning mixed connective tissue disease, and SLE with other connective tissue diseases. Other manifestation of the SLE is elevation of the hemidiaphragm due to myopathy, or pulmonary vasculitis, again with pulmonary arterial hypertension and enlarged pulmonary artery. Patients with SLE, they are prone to DVT with pulmonary embolism and infarction. COP, cryptogenic organized pneumonia, may occur. And also there is superior rib erosion, similar to rheumatoid arthritis. Other connective tissue disease is scleroderma. Progressive systemic sclerosis is multisystemic disease. Lung involved pathologically in 90% and radiologically in 25% of cases. In the chest X-ray we see cause reticulonodular opacification, and in CT we see ground glass opacification, which eventually cause fibrosis and bronchiectasis. As in these cases, we see some reticulation, ground glass opacification, area of increased density, and some area of traction, bronchiectasis. With advancing fibrosis, there will be progressive loss of lung volume, decreased lung volume. We may see large subpleural lower lobe cystis with spontaneous pneumothorax. Again, pulmonary arterial hypertension may occur, like rheumatoid arthritis and SLE. Pleural effusion is less common than in rheumatoid arthritis and SLE. It's a good distinguishing feature. Pleural thickening may occur due to extension of fibrosis to interstitial layer of the pleura, and it is not due to pleuritis. Other radiographic finding in scleroderma is axial calcification of mediastinal lymph node. There is esophageal manifestation of scleroderma, like esophagus may be dilated and filled with aspiration and secondary aspiration pneumonia. There is greater risk for lung carcinoma, especially bronchoalveolar cancer, and it may be part of the Cris syndrome with the calcification in the subcutaneous tissue of chest wall. Superior rib notching is another finding. What we mean by overlap syndrome and mixed connective tissue disease. Overlap syndrome, when patient has feature of more than one recognized syndrome with thoracic manifestation characteristic of the other disease. For example, patient scleroderma and SLE, scleroderma and rheumatoid arthritis. This overlap syndrome. But mixed connective tissue disease is SLE, scleroderma, and polymyositis. All these together, they sharing this features of UIP and fibrosis, pulmonary arterial hypertension, and pulmonary effusion and thickening. In this case, pleural effusion and thickening is mainly due to SLE. We have idiopathic chronic interstitial pneumonia. They denote inflammatory process in the lung that can result in pulmonary fibrosis. Any inflammation that results in pulmonary fibrosis. They are characterized only histologically, either usual interstitial pneumonitis, acute interstitial pneumonia, COP, RBI, LD, desquamative interstitial pneumonia, and non-specific interstitial pneumonia. If histology known, we can describe particular disorder, for example, COP, AIP. But if you don't know the histology, we can use the term idiopathic pulmonary fibrosis or rheumatoid lung. Better to use idiopathic pulmonary fibrosis. The most common of interstitial idiopathic pulmonary fibrosis is usual interstitial pneumonitis. It results from repetitive lung injury with inflammation followed by repair and eventually fibrosis. Usually occur in old age, in the 5th to 7th decade, and more in male. Most are idiopathic. 30% may be due to collagen vascular disease or immunological disease, and rheumatoid arthritis is the most common. Radiological manifestation. In the early stage, chest X-ray may be normal, despite positive clinical feature and abnormal pulmonary function test. Early radiological changes are fine reticular opacity with ground glass opacity. As disease progresses, the fine reticular opacity becomes coarse, and we may see honeycomb cyst with loss of lung volume. Extensive pulmonary fibrosis may be associated with findings of pulmonary arterial hypertension, طبعا secondarily. This is a case of usual interstitial pneumonitis. This is maybe the progressive disease. There is coarse reticulonodular opacity. On section CT, it depends on the stage of the disease. One important feature of UIP is that it varies from one lung region to another, not uniform. When there is active inflammation, it shows ground glass opacity. Ground glass opacity and reticulation. They are most severe in the peripheral and basal portion in the lower lung. It helps in differential diagnosis from other diseases, sometimes associated with mediastinal lymph node enlargement.
That's what they call apicobasal gradient. It starts less in the apex and increases as you go to the base.
Yes.
Gradient.
Yes.
It's one of the most helpful features in diagnosing UIP or IPF.
Yes. But when it reaches to the end stage, it will cause fibrosis with signs of end-stage fibrosis like honeycombing, traction bronchiectasis. There is an increased incidence of carcinoma, mostly adenocarcinoma. Another topic of idiopathic pulmonary fibrosis, acute interstitial pneumonitis. It is acute, aggressive form of interstitial pneumonia and fibrosis. It is pathologically like that of acute respiratory distress syndrome and sometimes regarded as idiopathic ARDS. We see it is diffuse and homogeneous, and radiographically it is similar to ARDS. We see diffuse ground glass opacity and consolidation with air bronchogram. We see this is diffuse airspace opacification. In the CT we see areas of consolidation, ground glass opacification, and also air bronchogram. One important feature is gradient of increase in density from anterior to posterior if the patient supine. There is gravitational effect. But it is acute, so that is why features of fibrosis like honeycombing and traction bronchiectasis are uncommon. Although fibrosis can develop, but tends to stabilize, not reaching the end stage. COP and cryptogenic organizing pneumonia is deposition of granulation tissue in the peribronchial airspace and bronchioles. Most cases are idiopathic. At that time you say cryptogenic. Cryptogenic by cryptogenic it means uncertain origin. But when it is secondary to other condition, It is called bronchiolitis obliteranis with organizing pneumonia, maybe due to viral, toxic, collagen vascular disease, post-transplantation, drug reaction, and chronic aspiration. COP differentiated from UIP. COP uniformity of the histological changes, while UIP variable from region to region. And in the UIP, you may see different pathology or different stage of pathology in the same time. It's called temporal heterogeneity. In the COP, there is no parenchymal distortion and no fibrosis, while UIP characterized by fibrosis. COP has more favorable prognosis and responds rapidly to corticosteroid, while not in the case of UIP. In the chest X-ray, we see patchy bilateral airspace or ground glass opacification, while in the CT scan, also we see consolidation, areas of ground glass opacification. They are usually subpleural and peribronchial. Bronchial wall thickening can also be seen. An important sign to diagnose COP is reversed halo sign. Reversed halo sign denotes to an area of ground glass, this ground glass, surrounded by more dense area of consolidation. It is not specific but suggestive of the disease, and diagnose at even sometimes COP cannot be diagnosed and needs biopsy to see the characteristic histological changes. Respiratory bronchiolitis associated interstitial lung disease seen in cigarette smoker, heavy smokers. They are typically young. Characterized by inflammation within and around the respiratory bronchiole, but there is no progression to end-stage fibrosis. Chest X-ray may be normal or show diffuse linear or nodular opacity and bibasilar atelectasis. In the thin section CT, we see scattered ground glass opacity, centrilobular nodules may also be seen. We may see emphysema because the small airway disease and cause air trapping, but honeycombing is not seen. The disease doesn't reach to the stage of fibrosis. Desquamative interstitial pneumonia cannot be reliably differentiated from UIP, but there are some helpful feature. It is diffuse and temporally homogeneous, while UIP is more lower pole, peripheral, and heterogeneous. It is invariably associated with heavy smoking, 90% of cases. They are younger, mean age is 40 to 45, while UIP 50 to 70. It is more steroid responsive and more favorable prognosis. 5-year survival is about 12 years, while in the UIP is about 4 years. Chest X-ray may be normal or show bibasilar reticular opacity. In the CT, we see ground glass opacification, diffuse ground glass opacification, but honeycombing and traction bronchiectasis, a sign of fibrosis, are less common than in UIP. We see in this case just ground glass opacification and some reticulation, otherwise no fibrosis. Nonspecific interstitial pneumonitis is a recently introduced term. Cannot be when there is interstitial pneumonitis, but cannot be classified as either of these conditions, UIP, AIP, COP. We regard it as nonspecific interstitial pneumonitis. They are mainly seen in association with collagen vascular disease or drug reaction. Again, pathologically is temporally homogeneous. It is diffuse and homogeneous. Again, reverse to UIP, which is heterogeneous. You have cellular and fibrotic type. In the cellular type, you have area of ground glass opacification and consolidation, as in this case, ground glass opacification and consolidation. Cellular type responds to steroid, while fibrotic type present as bronchial dilatation and linear opacity. They have poor prognosis, similar to that of UIP. From the name, because it is fibrotic. even at that time, it is more responsive and than UIP. This is a case of Scleroderma, complicated by fibrotic nonspecific interstitial pneumonitis. We see basal reticulation, ground glass opacification, and areas of traction bronchiectasis. You have some neurocutaneous syndromes like neurofibromatosis. Neurofibromatosis, we have type 1 and type 2. Lung involved in thoracic manifestation in the NF1. There we may see cutaneous or subcutaneous neurofibroma. We may see kyphoscoliosis. We may see rib-on rib deformity and rib notching. But in the reverse to connective tissue diseases, the rib notching in neurofibromatosis is inferior. Mediastinal masses may be seen in neurofibromatosis due to neurofibroma, lateral thoracic meningocele, or extraadrenal pheochromocytoma. Lung involved in 20% of cases, usually diffuse interstitial fibrosis, lower lobe, they are lower lobe and symmetrical. At the same time, you may have bulla in the upper zones, but they are asymmetrical. Tuberous sclerosis, involvement of the lung is rare in about 1%. In general, indistinguishable from lymphangioliomyomatosis. In the early stages, we may see reticulation. In the later stages, it will develop to small cystic spaces. The cysts are characterized by uniform size, while in lymphangioliomyomatosis, we say they are different size, but same shape. They are about 2 millim to 20 millim in lymphangioliomyomatosis. While in the case of tuberous sclerosis, they are less than 1 centimeter, less than 10 millim, and they are of the same size. On the CT, we see the small thin wall cystis with the extrapulmonary abnormality, tuberous sclerosis, multisystemic disease. Again, may lead to pulmonary arterial hypertension in the late stage. Lymphangioliomyomatosis is seen exclusively in women. Chest X-ray may be normal, or in the later stage show reticular nodularity, and late stage show cystis and honeycombing. They are thin wall, as we say. Lung volume is normal or increased. An important feature of lymphangioliomyomatosis is chylous effusion due to lymphatic obstruction. Lymphatic obstruction will cause chylous pleural effusion, chylioperitoneum, chylopericardium, or lymphadenopathy. This is a case of lymphangioliomyomatosis. The whole lung is replaced by thin walled cystis. They are different shape, they're different size, but the same shape. And we see normal lungs in between the cystis. Thank you.